Thank you, Deborah. Thank you. Thank you. All right.
Okay, I think it's should be able to do this one in a half hour or so. So hopefully people like it. But this is a 35-year-old man presenting with fatigue. And let me just give you a little bit of the HPI here. Oh, I'm sorry, I forgot my video. So he reports that 1 week ago, he started feeling fatigued and reported some subjective fevers, but he just said he just felt warm. He never actually checked his temperature. And he said he went to an outside urgent care facility, and he said that they told him that his creatinine was 2.5. He didn't have any prior labs or didn't really know what that meant, but he was told to come to the ER. And he said that he'd maybe had some foamy urine during that time, but really denied any other symptoms. No dysuria, hematuria, any abdominal or flank pain, weight loss, anything else. And he continued to feel poorly, had continued fatigue and what he described as brain fog. He just wasn't quite as sharp or quick as usual. And that's why he came. And he didn't have any chest pain, dyspnea, swelling, lower extremity swelling, diarrhea, or really anything else. I think that's probably a good place to stop.
I want to start, Alec. Thank you so much for presenting the case. So we have a young guy, a 35-year-old, who's coming in initially with just fatigue, which is very non-specific. And as we delve through the case, it turns out that for now, with the elevated creatinine, we can say this patient is having an AKI. With an AKI, the question is like, oh, is this an acute rise? Everything about this patient's symptomatology, the fact that he's having fatigue, brain fog, makes it seem that this illness is new. It's not something chronic that has been going on. So for now, I'll frame it as an acute kidney injury and see and with additional details about his background and labs, and maybe we can do a little bit more progress. So AKI in a young guy, I think base rate, we always say, is clean. So thinking about the base rate, pre-renal, post-renal, like pre-renal being effects of hemodynamics, and then the post-renal being kind of the plumbing. Where like the kidney itself is fine, but if you put that kidney into somebody else, the kidney functions well. But it's the rest of the problems that is causing kidneys to stress out. With a post-renal, usually the ones that come to the group of people that I take care of are like older gentlemen's BPH. Usually it's one of the reasons why people have post-renal AKIs. In addition to, like, you can think about UTIs, anything that with a big prostate that causes urinary retention. Stones probably need to be bilateral in order for do that. So in a 35-year-old young guy, like probably a little less likely. However, anatomical issues may be something to think about, and then external compression is the other one, especially if there's like a lot of like adenopathies that are causing your masses that causing your ureters to clamp down. So something to think about. And the pre-renal, usually the things we to think about is either effect of hypovolemia. If he's like fatigue, he's not eating and drinking. Alec gave us some really good info about the fact that like he hasn't had any diarrhea. So like getting a better sense of like his input, if he's been, if we say like that warmth is fevers and he's having chills, is he losing a lot of insensible losses, and that could explain his AKI? Maybe. However, I think in a young guy, we have to think a little bit deeply about that. And then the other one is like effects of hemodynamics, thinking about, heart failures, liver failures, those things causing it. But in this case, I think usually I don't invoke our intrarenal etiologies at much. However, there is a clue here to make us want to think about that. So I'll pass the mic to Jack to talk about that.
Oh, I love it, Charmaine. A tour de force of AKI. And I appreciate so much sort of taking both the general framework of an AKI, because that's going to be the dominant energy here. And then we can sort of play with some of the company that the AKI is keeping, the brain fog and the foamy urine, but keeping in mind the fact that it's not going to take away substantially from the type of workup that we might do in terms of pursuing all of the other buckets. And so when we ask ourselves, well, what is the company that the AKI is keeping? There's two things that we have here. We have brain fog and we have foamy urine. Now, classically, foamy urine is a buzzword that we use when we think about the term proteinuria. And so if we ask ourselves, well, what are some things that could lead to proteinuria in an acute kidney injury? It's going to localize us to localize us to the intrarenal causes, like Charmaine mentioned. And the two big intrarenal causes that we're going to think about in terms of things that could lead to proteinuria in large amounts is going to be glomerular pathology. And that could be an acute glomerulopathy, which could cause something like nephrotic syndrome or nephrotic range proteinuria, or an acute inflammatory process of the glomerulus, right? Like a glomerulonephritis. So then the question becomes, well, gosh, if we take those two possibilities, foamy urine, so in terms of thinking about nephrotic syndrome and glomerulonephritis up front, we have to ask ourselves, does the base rate of disease make us need to prioritize that yet? And I think the answer to that question is no. We're still going to think about causes of pre-renal and causes of post-renal, like Charmaine mentioned, but we're going to be finely attuned to the possibility of intrarenal pathology, which we can get quite a quick answer to the possibility of glomerulopathology based off of the urinalysis. If we see large proteinuria, if we see proteinuria and hematuria combined, that's going to then lead us to prioritize an intrarenal pathology up front. But as Charmaine said, more often than not, we prioritize pre and post in the initial phases. The next question is, well, what do we make of the brain fog? And I will say brain fog is such a non-specific symptom, and it's so common that can come with acute kidney injury, particularly if the AKI is leading to things like other electrolyte abnormalities, for example, hyponatremia, something that we can see, but also uremia, and an elevated BUN can certainly lead someone to be confused. And so I think where we're going to go from here is going to be our sort of operationalization of the acute kidney injury workup. We're going to try to get a sense of his volume status based off of the exam. We're going to think about risk factors for post-renal disease, like Charmaine mentioned, thinking about stone, strictures, and BPH. And then we're going to really examine closely and quickly the possibility of intrarenal pathology, right? We don't see some of the classic symptoms of nephrotic syndrome, like lower extremity edema, but those can take quite a long time to develop. And in an individual who's young, you may not see profound lower extremity edema, even in the presence of marked proteinuria, just because of their ability to compensate. So the UA is going to be particularly helpful here for helping us calibrate the probability of intrarenal pathology, in particularly glomerular pathology up front.
All right, excellent discussion. So I'll get into the other history briefly. So it's a history of hypertension diagnosed about 5 years ago, for which he takes amlodipine 10 milligrams daily. It says that he's regularly adherent to that. No surgical history, no allergies, no family history that he is aware of. From a social history perspective, no tobacco, alcohol, or drug use. He is originally from Nicaragua, but has been in the US for the last 18 years, living primarily in Houston, and works in construction, is monogamous with one sexual partner. And I think for the purposes of time, maybe I can give you the physical examination as well. So vitals wise, afebrile, and heart rate is 94. Blood pressure is 155/99. Respiratory rate of 18, saturating 100% on room air. His BMI is 35. In general, he looks well. He feels a little bit fatigued. He has moist mucous membranes, no lymphadenopathy in the neck. His cardiopulmonary exam is unremarkable, as well as his abdominal exam and neurologic exam. He's alert and oriented ×4. He has no focal deficit and no lower extremity edema either. So pretty unremarkable physical exam.
All right. Well, I will say that I think looking at elements of the background past medical history, I think it is helpful to know that this gentleman has hypertension, and I think noting that he is still hypertensive here today during our visit makes me think about two things. One, there's the possibility that this hypertension has not yet been adequately controlled, which is important to know because that increases the risk of not necessarily acute kidney disease, but chronic kidney disease and hypertensive nephropathy, which certainly could contribute, for example, to things like progressive renal injury, as well as potentially leading to acute kidney injury, right? But I think understanding now that there is hypertension in the background, we would think about chronic kidney disease, but it's also important to notice that it's the time course for which he has had hypertension of only 5 years would be quite abrupt for us to be seeing this degree of renal dysfunction as a result of chronic kidney disease, right? Usually we think of it taking not necessarily years, but actually decades for CKD to set in from hypertension. So one hypothesis is that the hypertension is mediating his underlying renal disease. The other hypothesis is that the ongoing hypertension could be a complication of whatever acute kidney injury he is having, right? If we think about renal or causes of acute kidney injury that could be accompanied by hypertension, it again prioritizes the intrarenal category. For example, a classic illness script for glomerular nephritis or nephrotic syndrome will oftentimes include hypertension as well. So one of the things I'm thinking about in the back of my head is the 155/99 his baseline, or is it 30 points higher from his previously well-controlled hypertension? And that can help us again frame the probability of intrarenal pathology here. But those are the things that are sort of jumping out for me. Again, understanding whether it's worsening hypertension or just longstanding yet to be controlled hypertension is important for stratifying the probability of a possible intrarenal acute kidney injury. Charmaine, what else is jumping out to you here?
Yeah, I love that, Jack. When Alec was giving us the past medical history and he said hypertension for the past 5 years, I was like, oh, a 30-year-old guy with hypertension. So I think one thing to keep in mind, whether that is related to this acute presentation, is what workup has been done for that hypertension. I think as in a 30-year-old who is coming in with hypertension, like it's worth thinking about the secondary causes of hypertension. He has elevated BMI, so he's at higher risk of metabolic syndrome, and I wonder if it was attributed to that. However, it's worth a pause at that time. And in terms of like his exam, it is with the kidneys, the kidneys hide inside, and sometimes we don't have a manifestation. And as you mentioned, a lot of the time the younger people can have lower extremity edema and stuff like that. So so the exam, I think we just see the hypertension that he has. And the other thing that is like helpful is like what is not there. So no rashes, you don't see any palpable purpuras, anything that kind of like makes you think of perhaps a more systemic disease involvement. At least on the exam, we don't have that aspect of it. But so I think this is a case that will just rely a little bit more on our lab and workup, which I'm sure this patient got. So Jack, any other thoughts before we pass the mic to Alec?
I don't think so. Yeah, I think I'm still at the point of really wanting to localize within the framework that you mentioned. And I think while we've had some helpful information that has weighed the probabilities of pre, post, and intra here, just based off of the epidemiology and some of the exam features, it's hard to necessarily move beyond the sort of initial pretest probability that's going to prioritize pre and post here. And so I'm really excited to see what we find on the labs, and especially on the urinalysis here.
All right, excellent. So I can give you some more information. In regards to the CBC, the white count was 8.7 with a normal differential. The hemoglobin was 8.2. Normal for our lab is 13 to 17. Platelets were 189. As far as the BMP is concerned, the sodium was 112. The potassium was 3.2. Chloride of 78. CO2 of 24. BUN was 28. creatinine was 2.5, glucose was 106, and the calcium, magnesium, and phosphorus were all normal. Don't have any liver chemistry tests here. I did not write down the albumin, so I apologize. And then moving on to the urinalysis. So he had a specific gravity of 1.003, 2+ protein, no RBCs or WBCs noted. And for the purposes of time, the urine protein to creatinine ratio was 4. He had a ferritin that was 120, normal B12 and folic acid. A haptoglobin was normal. And the PTH was 200. And a normal plasma renin to aldosterone ratio and plasma metanephrines.
Take it away, Sharmi.
Wow. I mean, I just want to appreciate that this 35-year-old is walking around with just a brain fog with a sodium of 112. Mind blown. But okay, I will leave that for Jack. I'm going to focus on the CBC. CBC, the anemia surprised me. So the patient's anemia is like quite anemic at 8.2. So the question becomes like, why? And if you think about, his fatigue, could this acute anemia, I'm assuming it's a acute, just have acute anemia. And when I think about that, you think about blood loss and hemolysis being the second one that can cause a rapid thing. Haptoglobin is quite specific. And I think the haptoglobin was normal, but it's worth getting a smear just to make sure what is going on with the hemoglobins, and kind of thinking about any blood losses that this patient could have had and the places that it can hide, as well, thinking about, abdomen, GI tract, like abdomen, thorax, and thighs are the places that blood can hide from you. We don't have any story of like acute bleeding. So the question becomes, is this more of like a subacute or chronic that perhaps this patient, if he hasn't been in care for a while, but this has been going on, his vital signs are completely normal if this was an acute drop. So that kind of moves us away from like the acute etiologies that still should be considered, and moves us to like, oh, is it anemia the driver, or is it the side effect of what is going on with his kidneys, and if this has been going on for a bit longer than we had initially thought. So Jack, take us away. I know you love hyponatremia, so I decided to leave that for you.
Thank you. I do very much enjoy hyponatremia. So I think there's going to be sort of 3 key tests that we're going to use to understand this individual's hyponatremia. The first one is going to be the serum osms, but I think we can presume in this case that this is almost certainly going to be a hypoosmolar hyponatremia. We don't see profound hyperglycemia. We don't have a history of heavy alcohol use. We haven't had recent contrast administration, things that can cause a hyperosmolar hyponatremia. A isoosmolar or a euosmolar hyponatremia is usually pseudohyponatremia from, for example, a very, very high paraprotein level. And so we can say that the probability of that seems very low as well here. So within the hypoosmolar categories, our next 2 important tests are going to be the urine osms and the urine sodium. The urine osms can help us answer the question of is ADH on or off? Now, there is a separate test that we can use to get a rough estimate of what someone's urine osms are going to be before that test comes back, and that is the urine specific gravity. We can see a specific gravity of 1.003 here is a very, very dilute urine. That is almost the same specific gravity of, for example, water. Now, somebody who has very, very dilute urine in the setting of hyponatremia is very likely not able to concentrate their urine effectively. So that may push us into the low ADH category, which could be related to things like, for example, primary polydipsia or, for example, a tea and toast diet or beer potomania. So those two things could be drivers of this individual's hyponatremia here if the urine osms are indeed quite low based off of what the specific gravity tells us. Other things that are really standing out here, though, is also the fact that in addition to having significant hyponatremia, we also have what seems to be a relatively large amount of proteinuria. Now, lots of different labs report these values differently. And so really what we want to be able to understand is the protein to creatinine ratio and how that would translate or calculate into somebody's 24-hour protein excretion. And so, Alec, at some of our, or at least at where I practice, the urine protein to creatinine ratio would correlate to grams of protein per day. Is that also how you all interpret that? Does this urine protein to creatinine ratio suggest 4 grams per day of proteinuria, or is the decimal place different for you all?
No, that is correct. It's an estimate of the 24-hour urine.
Awesome. So based off of that information, we also have an amount of proteinuria that is putting us into the nephrotic range proteinuria category here, right? We don't necessarily have the nephrotic syndrome, right? Because we don't see other findings like very, very low albumin and profound lower extremity edema, but we are looking at nephrotic range proteinuria with the protein of 4 grams per day. Now that could be things related to, for example, actual glomerulopathy causing large amounts of glomerular proteinuria, or it could be related to things that can cause nephrotic range proteinuria without nephrotic syndrome, for example, diabetes, which we don't necessarily have here, or IgA nephropathy. IgA nephropathy is an intriguing diagnosis to consider here because of the fact that we do have hematuria as well. And in a young individual with isolated hematuria as well as large proteinuria, it is a certain possible cause here. So then I think the question becomes, well, where do we go from here with this? And I think we have sort of 2 parallel tracks that we want to characterize. One of the parallel tracks that we want to characterize is going to be, what is the underlying cause of the hyponatremia? We said that one of the possibilities is from, for example, a hypo or a low ADH state where the individual is going to be consuming or unable to concentrate their urine, which is, again, could be from a primary polydipsia or very high free water intake, or a tea and toast diet, which could be related to very, very low solute intake. But there's also the possibility that there is severe renal dysfunction and water retention, right? Because this individual is not able to actually excrete free water because of the degree of renal dysfunction. So I think the question becomes, is the hyponatremia the center of gravity, or merely a consequence of this individual's renal dysfunction? It's hard to imagine somebody having a sodium of 112 with it not being the center of gravity. So I suspect that there is something contributing to that. But then also in isolation, we have to work up this large proteinuria and some of the hematuria, which oftentimes the most efficient diagnostic pathway to get there is going to be through a kidney biopsy. So I think right from as internists, we can do some work in terms of both evaluating, but also working to hopefully treat this individual's hyponatremia with the help of our nephrology colleagues, and then also asking them, do you all think that this degree of proteinuria warrants a kidney biopsy to get a diagnosis here? And as we said, I think some of the things that could cause the combination of proteinuria and hematuria in a young patient like this would be something like IgA nephropathy, as well as many of the other things that could cause nephrotic syndrome, although we're not necessarily in that specific disease entity right now. So Alec, take us forward from here.
All right, excellent. I just want to clarify that it was 2+ protein, but there was no blood, no white cells. So just only protein there. But yeah, just to build off your excellent discussion here. So we did some additional serologic workup. So we checked NHIV and hepatitis panel, both of which were negative. The hemoglobin A1C was 5.7, so normal for our lab. The serum and urine protein electrophoresis and serum free light chains were all normal. He had a anti-PLA2R antibody to look for primary membranous nephropathy, which was negative. He also had a negative ANA, anti-GBM antibody, ANCAs, and double-stranded DNA. A negative treponemal antibody and normal complement levels. He did undergo a renal ultrasound with Doppler The kidneys were about 10 centimeters bilaterally. There was some increased echogenicity, no hydronephrosis, no evidence of renal artery stenosis, and did ultimately undergo a renal biopsy, which showed secondary focal segmental glomerulosclerosis. And just like Jack really honed in upon there, that the hyponatremia was what was really the center of gravity of the case, and so that's what I decided to frame it around. So to give you some more information there, the serum osms were 246. The urine osms were 120. And the urine sodium was 24. And the TSH and free T4 were normal, and an AM cortisol was 18. And the next outcome will reveal the diagnosis.
I mean, I talked a ton in the last auto class, so I'm going to turn this one over to you.
Okay, I'll go through some of the lab and then I will let you finish off your hyponatremia discussion. How about that? All right, thank you so much. This is such a fascinating case, Alex. So kind of looking through the other labs that was done. So, with nephrotic range of proteinuria, what are we thinking about, right? We're thinking about membranous etiologies, we're thinking about focal segmental glomerulosclerosis, minimal change disease, and then the other etiologies and that I'll go through in a second. So how does those labs help us even before getting the biopsy make progress? I really appreciate this thorough workup that has been done, especially like thinking about primary membranous. Usually the PLA to RIB is up. It's like has good sensitivity specificity. Thinking about like secondary causes of membranous, a lot of the autoimmune etiologies can do that, from like lupus to cryo, as well as like some other infections like Hep serol, like thinking about like infections. And then when it comes to the focal segmental glomerulosclerosis, again, we have primary etiologies and that's secondary, with HIV infection being a secondary. And the other causes of like glomerular hypertension can lead to FSGS as well. So, elevated BMI, like in this case, obesity can do it. And then there are like also secondary causes tend to be less common, with the primary focal segmental glomerulosclerosis being more likely initially, but the secondary causes to think about is like HIV infection and glomerular hypertension, mostly in the setting of obesity. And the minimal changes, we usually think of it more, as in the disease of kiddos, and again, biopsy didn't show this, but again, like there are secondary causes such as like cancers like lymphoma and some meds like lithium that can do it as well. And in the other things to think about, like paraproteinemia, we talked about IgA, that can do it as well, in addition to diabetes. So in this case, I think I heard correctly that if the biopsy was a secondary FGS, so in the causes of secondary, going back to it, HIV was negative. So I wonder if this is mostly in the setting of the patient's obesity. Is my initial thought. I love that. I didn't know about the syphilis. So thank you. The chat is saying that troponin antibodies should be tested as well. Jack, what are your thoughts?
I think that was phenomenal. I love the discussion. I think that this is just an awesome case to think through. And I think, this is honestly a bit of a rarer side of the hyponatremia schema than what we usually find ourselves in, right? With the information that Alec has given us, right, we have confirmed hypotonic hyponatremia with the serum osm of 246. We have urine osms that are on the lower end here, right, which tells us that that this individual is having a difficult time concentrating their urine effectively. And then also the urine sodium in sort of the normal range here. So the question becomes, are we dealing with unimpaired ability to dilute the urine, right? Is this free water or is this very, very dilute urine an appropriate response to very, very high water intake or very, very low solute intake? Or is this actually impaired urinary dilution for example, from the degree of renal dysfunction. And I think this is a place where honestly, I would go back and speak more to the patient to get a sense here of what things could be going on and whether or not there are potentially multiple factors contributing here, right? The fact that this individual has secondary FSGS tells us that there is almost certainly, and the fact that the creatinine is 2.5 tells us that there is some degree of renal dysfunction here. So that means that there is potentially the kidney is having trouble, is going to be having trouble effectively concentrating their urine or diluting the urine, for example, and that could contribute to water retention and hyponatremia. But the urine osms being this low makes me think that there is potentially another contributor here. For example, a very, very high free water intake or very, very low solute intake from potentially feeling unwell. And so renal dysfunction here could be exacerbating the hyponatremia because of free water retention and difficulties excreting free water because of renal dysfunction. But I would be hard pressed to believe that it's the primary driver on the hook here because we don't necessarily see other primary causes or other primary findings of significant renal dysfunction. The BUN isn't super high. The potassium is actually quite low rather than being quite high. And so other things that could be going on here is we could be seeing coexisting tubular dysfunction, for example, but I do wonder if there is a component of either primary polydipsia or very, very low solute intake, which in the context of this renal insufficiency and the difficulty excreting free water could be driving the prominent hyponatremia that we see here. But beyond that, I think we would be stepping well beyond the bounds of my knowledge. I think I've taken the discussion to the edge of what I feel comfortable sharing, and so I'm really excited to learn from you, Alec, kind of where your team settled here on what the final answer is. Charmaine, any other thoughts?
No, that was beautiful. I can listen to you talk about hypernatremia all day, my friend. That was fantastic. Can't wait to learn from you.
Yeah, absolutely. And Jack, like the team and I had, very similar thoughts to you. And we decided this was actually a patient that was transferred out of the ICU at the time. And we decided to go back and speak to him a little bit more. And it turns out that after he went to the urgent care and he heard about his kidneys, he was very, very concerned and anxious about this. And so he was drinking an entire 24 pack of water, so 12 liters of water for the 3 days prior to presentation. And he got some 3% salines monitoring the ICU, and his sodium got better. His renal function stayed about the same, and was felt, he was only diagnosed with hypertension 5 years ago. He could have had it much longer. He didn't have much access to medical care. And then, perhaps his obesity also was felt to contribute potentially to the secondary FSGS. So this was a case of primary polydipsia on top of secondary FSGS, and just an amazing discussion. And thanks for letting me share the case.
Thank you so much, Alex. It's an absolutely awesome case here. And really kudos to you and the team going back. I was curious if you learned, I think one of the things that I'm finding a point of confusion for myself here in thinking through this is if in the setting of the renal insufficiency, that would make it more difficult for the patient to concentrate their urine or more difficult to dilute their urine. Did you all talk about that at all?
Yes, and that's an excellent point. And so it's actually probably a mix of both. And you could argue that for a patient who doesn't have normal tubular function, because his creatinine is 2.5, that the kidneys being able to dilute the urine to 120 osms is actually pretty good. Because a normal person would be less than 100. So we felt that was, a sure sign that the ADH was off and that his kidneys were doing the best they could. But with the underlying renal impairment, as you discussed, that was the max that his kidneys could dilute things, and that was also a contributor to the severity of the hyponatremia.
Right. So, if his creatinine had been normal right now, he may not have gone down to 112, but there may have been some more compensation for the high water intake, but because of the renal dysfunction, the kidneys couldn't respond in the direction that they needed to, which is diluting the urine even more.
Exactly, right. They couldn't, get the osms down to, less than 100 or 50 because of those limitations.
Yeah.
Yeah, it was such a fantastic case. Thank you so much, Alec. And I think like for me, the pivot point was the labs. Sodium of 112 with like creatinine of 2.5. There's just a that doesn't make sense, right? Like the kidney function is, yeah, he has an AKI, but the degree of hypernatremia is not just explained by that. So making sure to pursue another cause. And a lot of the time, hyponatremia, in my experience, is like multiple etiologies. We're very good at trying to maintain our sodium. So if it's down, think about multiple causes and not just one. So that was just a fantastic case, Alec. Really appreciate it.
Awesome. All right, Deborah, will take us home with the teaching points here.
Hi, everyone. Great case. Going for the teaching points, we started this young patient. We thought that could be something acute. It could be like a past medical history or a medication that could be caused. And then we went through the AKI and we thought about pre-renal causes, renal and post-renal. Going for the pre-renal, we thought about the hypovolemia, heart failure, liver failure. Renal, we thought about nephrotic and nephritic syndrome, and post-renal, we thought about the prostate, but this patient is young, so we didn't focus on that. And the proteinuria, and the causes could be nephrotic syndrome or glomerulonephritis. And in this patient, we can see that the edema can take more time for this patient have the edema. And the past medical history, the patient had hypertension and it was hypertensive now. So Jack said that could be two hypotheses, that is not controlled, that could be a chronic kidney disease or can be a complication for an acute kidney injury. And we think about secondary causes like a metabolic syndrome, a renal vascular hypertension, a renal arteriosclerosis. And going for the labs, he had like anemia that could be acute, and we thought about hemolysis, and could be a blood loss in the GI, in the thorax. And the hyponatremia, we have three key tests like serum osmolar, or urine osmolar, and urine sodium. And if the patient has difficult time to concentrate, we can think that could be impaired to dilute the urine or impaired to the renal dysfunction. And in this case was more likely a renal dysfunction. And we thought about the secondary causes of FSGS that could be like heroin abuse, the anabolic steroids, skin cell, lupus, HIV. And now in the end, Charmaine said that the lab of the hyponatremia and the creatinine of 2.5 doesn't make sense, that we can think about the hyponatremia can have multiple causes. So yeah, thank you everyone. I see you all tomorrow.
Awesome. Thank you all so much for a great case today. Alec, thank you again for presenting. Mukund, thank you so much for scribing. And thank you all for being here. Charmaine, it's always a treat. I'm so happy to get to be back and doing this again.
And you got a hyponatremia case.
Woohoo!
Alec, I just want you to know that you made Jack very happy today.
I am also a fellow hyponatremia lover, so you know, I love that we could share that together.
Those people who love hypercalcemia can go find somewhere else to hang out.
Rude.
You and Dan can start your own club.
Sodium is greater than calcium, no question.
I love sodium, but I feel like I have to stand up for calcium because everybody else is like hyponatremia, gotta represent.
That's fair. You're supporting the underdog.
And then that very nerdy note, thank you all. Bye.